Good evening, everybody. Welcome to tonight's webinar. We're really quite honored to have Dr. David Nabarro speaking to us tonight. He is one of the most distinguished figures in immunity, infection diseases, and epidemiology internationally. In addition to which, another claim to fame is, of course, he's the grandson of the former president of the predecessor organization, the London Jewish Medical Society. And he and I have discussed the question of his grandfather's role as a distinguished pediatric pathologist. I'm sure that's an original introduction, but you haven't come to listen to me, you've come to listen to him. So I'll hand you over to David.
Well, David, thank you very much indeed. What a lovely introduction. And I've been looking forward to tonight a lot, partly because my grandfather, my namesake, really was very keen on his own involvement in the predecessor organisation, and partly because it gives me a chance just to explore a bit some of what I think we're going into now in the current phase of the COVID-19 pandemic. And I thought the best way to share this with you tonight, and tuning into the theme of the title that I've been given, is to focus on what I know, focus on what I suspect, and then focus a bit on what I really don't know. And then using that, I want to try to weave a narrative for where I think the world is headed on the pandemic in the coming months and perhaps years. Sorry, I've got to just switch off my phone. So when I'm talking about what is known, I really like to talk about the virus, because that's what we're focused on. And it's the virus that's the problem. It's people that are the solution. And so what do I know about this virus? Well, it's new. And we don't know many coronaviruses. And we've never had a coronavirus pandemic that we're sure of. We think there may have been one a century or so ago. It's a virus that we're learning about more and more each month. We know that transmission is primarily by droplets, and that means close contact. It's not airborne most of the time. And that means also that it's always going to come in surges that'll build up and sometimes overwhelm populations and particularly health facilities. We know that the likelihood of a large surge developing will be influenced by the degree to which people have immunity. And we have vaccines that can help provoke immunity. And people who've been infected have a degree of immunity. But what we suspect is that it's quite limited duration, and extremely variable. And of course, as the virus mutates and variants develop, they'll have differing abilities to be able to evade immunity. And indeed, there's an evolutionary advantage, continued mutation and continued emergence of variants. Of course, a variant that's fitter will take over from its predecessors. And fitness is mostly expressed in terms of infectiousness. And so Omicron is displacing Delta. And there'll be variants coming after Omicron. And they may displace Omicron if they're more transmissible. And there's no guarantee that they're going to be less severe than Omicron. They may lead to a different pathology. And what's absolutely clear, and what I know for certain, is that it's not a good idea to underestimate this virus. It's still got quite a lot of tricks up its sleeve. And that's why tonight, as I conclude with what I know, I want to stress that we have the tools to be able to keep this virus at bay. We have the tools to be able to reduce the amount of virus in the society. We have the tools to protect people who get infected with the virus from being severely ill and dying. But we've got to use these tools together in order to be able to get on top of the pandemic. We shield people with vaccines, prevent them from dying. That's what the vaccines are really useful for. And then we prevent the virus from being transmitted by making it hard for the droplets to move from person to person. So we wear face masks, especially when we're in confined spaces. We maintain physical distance, we ventilate, and we practice good hygiene. But we do it all together, because we don't know enough about what this virus is able to do to people. We're seeing evidence with long COVID of people being really disabled for many months after their initial infection. We don't know the incidence of long COVID, but we think it's about 1 in 20. And we don't know enough about the mix of pathologies with long COVID to be able to estimate what it really is going to mean for humanity. But the recent publication of quite a careful assessment of long-term, that's several months, experiences after COVID do suggest that there's an increased risk of cardiovascular disease. And so, taking it all together, the conclusion certainly of the team that I work with at WHO, the World Health Organization, is that we actually must not take this virus lightly. We've got to do everything we possibly can to limit transmission. We've got to protect people through vaccination. And we need to continue to be careful, because all that we're seeing is that this virus is affecting poor people and poor communities and poor countries in a much more profound way than others. So, taking it together, what I want to do tonight is to finish my remarks with a little bit of a narrative that I believe ought to be more and more appreciated by leaders as well as by members of the public everywhere. We've got to protect people, prevent transmission, and prepare for surges of the disease that are going to occur from time to time, often prompted by the emergence of variants. We've got to focus all the time on those who are most vulnerable, people who are most likely to get severe disease and to die, people who've got concomitant illnesses, and people in the older age groups, health workers and others who are frequently exposed. And we've got to end this really unacceptable situation of inequity in access to vaccines, in access to tests, by treating this pandemic as a global pandemic and not as an issue to be focused on by individual nations in competition with each other. And we've got to ensure that nobody relies just on vaccination to try to address this pandemic. And we don't know the extent to which vaccines can reduce the circulation of the virus. We suspect that even in populations that are vaccinated, the virus is still circulating, possibly not with such intensity. So it just doesn't make sense to rely solely on vaccination as a way to handle this pandemic. There's got to be efforts to limit transmission, and there's got to be efforts to deal with surges when they emerge, to protect people, to protect services, and more. on the whole, we really suggest that lockdowns and any severe movement restrictions are only used as a last resort, and that instead the focus is on constant surveillance and active measures when clusters build up and surges start to emerge, to prevent transmission through well-organised case finding, contact tracing and isolation procedures. Because surges are going to go on happening, we have to build such procedures into public health everywhere. One of the reasons why poorer countries seem to have done remarkably well in managing this pandemic is that they've applied these procedures and applied them carefully, and they've had good results. In high-income countries, it's been less successful. Centralised test, trace and isolate schemes are not what's needed. It's an integrated, localised case finding and contact tracing isolation support system of the kind that's used so often in dealing with infectious diseases. These have got to be put in place, tested, and made to work, with the public understanding that this is what you do when you're dealing with surges of an infectious disease, especially with a virus that can be so dangerous. And so, as I come to the end, I want to stress that above all, in moving forward with this pandemic, and with any infectious disease outbreak, the one abiding requirement is that people are partners in the response and never perceive of themselves as somehow disliked or not accepted. You see, the one thing we learnt when I was dealing with Ebola in West Africa, or avian influenza in Southeast Asia, was that the only way you can tackle an infectious disease is if the people themselves perceive that they're at the centre of the response and are ready to adapt, shift their behaviour in ways that they learn that they can apply that will be good for them and good for their populations. It's what we've done as a society with many other infectious diseases, and we've done it well. So we don't want to see movement restrictions and lockdowns applied as the primary means of responding to surges. But we also don't want to see mandates applied that mean that people are compelled to behave in particular ways or to accept particular interventions. Because as soon as there are mandates, as soon as there are penalties for non-compliance, especially if these are perceived to be applied in an arbitrary way, there will be discord, and the discord will be politicised, and that in turn will have implications that will go beyond the pandemic. So the position that we're taking more and more is to ask nations, through governments, through businesses, through civic leaders, to do everything they can to make sure that no one is stigmatized or made to feel in any way not accepted in society if they choose not to accept certain measures. And we want to try to make sure that this injection of trust and shared responsibility is at the centre of the responses to this pandemic as much as we can make it in the coming months and years that we'll be dealing with it. Because otherwise, the prospect of a society that's unable to react to surges and unable to react to changes in the way in which the virus behaves starts to emerge. And we've got to be able to adapt and to change as necessary when the epidemiology requires us to do so. So with that, I've finished my remarks and would be really interested to enter into any discussion. And if there are things that I can't answer, I'll be very clear.
Right. Well, straight away, we've got two immediate questions that from two people who've been regular attendees and indeed participated in this area. The first is from Simon Minkoff, which says, I'll read it out. Your message of the measures required to control and limit the transmission of this virus is clear. But we see people not taking up the offer vaccine, not wearing a face mask with increasing frequency, slipping back into old habits of close proximity and poor personal hygiene. These people may be responding appropriately to their individual risk, but are not considering the risk this would present to others. How are we to respond to the challenges of allowing individual freedom of choice in a liberal democratic society?
And so the one thing that I would like to say has to be introduced as possibly the most important influence of all is the example of leaders. You see, if there is a consistent position by as many leaders as possible of the importance of mask wearing, of the importance of maintaining physical distance, and the importance of hygiene, ventilation, and protecting those who are most vulnerable. And that is practiced, as I say, consistently by leaders. Then we know, because we've seen it on so many other diseases before, that societies will be able to change. Now, of course, there'll be some who just can't maintain the example. There'll be some who want to demonstrate that they are different. But what's required is that the vast majority of leaders are able to adopt the practices that public health show is necessary. Now, of course, you'll say to me, you know, the horse has bolted. It's going to be really difficult to establish in a number of high-income countries, particularly in Western Europe and North America. It's going to be hard to get to a point where the discipline is there. It's much easier in Southeast Asia. It's much easier in Africa because people are used to be able to work together to deal with these kinds of diseases. It's going to be hard in Western Europe. But I think it'll come. I just think that we're temporarily going through a phase when people are having to let off steam. But once we realise that the virus hasn't gone away and that other variants are going to emerge, then I think that things will get back on track again. I'm not anticipating that the current situation is going to be what's going to last for a year or two.
One of the ways of population reacting has been described as COVID fatigue. Marcia Schofield raises the question, how do we deal with COVID fatigue, where people are exhausted in all sorts of kinds of ways by the virus, including the healthcare workers as well as the population? How does one address that?
Well, for me, the fatigue is in part caused by really quite marked shifts in the way in which countries have been trying to deal with the problem. And I think that if we could have been just clear from the beginning the basics of what's involved, and that is not letting the virus get out of control, keeping it at bay, without lockdown, but with well-organised surveillance and response systems. And if we can get that to be the steady state, then there won't be fatigue because it'll be part of the way we live. But of course, if there are these sort of intense lockdowns, keeping people confined for very long periods, and if there's also a lot of flip-flopping on some of the restrictions on how people can live, then it becomes intensely tiring and, for many, unbearable. And that's not a steady state. There's no way that if this virus is going to stay with us for the foreseeable future, that we can go on with the kind of flip-flop existence that we've had for the last 2 years. We've got to get to a point where, yes, we live with it, but we live with it by keeping it under control. We don't live with it by letting it go wild. And so I suppose what I'm saying is consistent leadership that says, yes, there are some basic principles that we're going to have to adopt, and they're going to be principles that we'll have to adopt for the foreseeable future. And here's what they are, and we can do it, and we can get on with our lives, whilst at the same time we can keep the virus at bay. Yes, we'll have to wear masks. That'll be inconvenient for some, and we'll have to keep our distance, and that will be tricky. But at least we can get on with life, and we can live, and we can have a social life, and we can travel. We just got to stick to some principles for how we behave. That's, I suppose, what I'm really saying. And I think that's, because it's going to be what life's going to be about, we're not going to be able to avoid it. I suppose I'm saying, well, let's sort of get settled down and organise what living with COVID really is going to be like. It's not going to be horrible. It's just going to take some adjustments to quite a lot of aspects of our daily lives.
I mean, Leora Harvard, who's an activist in general practice, has asked the question about how you feel about the UK restrictions being lifted, the uncertainties, and a doctor out there saying that in one mutation and another surge, and we have to be on guard. Is this just monitoring? And from what you've been saying, where's that monitoring coming from? Is it going to come from local, from
Yes.
governments, or how is it going to work? How does that fit with international agreements on how countries manage it?
Well, it's doable, it really is. There's a thing called the International Health Regulations, which sets out the principles for how you deal with these kinds of infectious diseases. It's just that nations didn't really follow what's in the regulations for all sorts of reasons at the beginning of this pandemic. But now we've had it for 2 years, and we know it's going to stay with us for quite a lot of time to come. And we would say, let's apply the international health regulations. And in Britain, there's rather a good sort of backbone of public health through district public health officers. And they know how to deal with these things. They set up integrated local teams to keep the monitoring, as we just said, in place. So you pick up variants and you can build that into how things work. It's not impossible at all. And in fact, it's what will happen. It's just have to get out of the current intensity and just plan for basic public health surveillance to pick up the variants and to deal with the surges as they come. You can build that in. And it's also doable globally, because the principles can be applied and are being applied in many other countries. In fact, that's why I say many African countries, particularly South Africa, are doing it really remarkably well, and they're building it in to how they run their public health services. And I think that's, as I say, is the pattern for the future. There's one other part of the question that I haven't answered, but it's because it's slipped out of my head, so I'm going to stop.
Okay. Right. That really addresses most of the issues. One of the questions which, as you've raised the question of Africa, one of the questions raised by a colleague of mine, Benny Chen, in the Times the other day, is the question of chasing the inequities and the inequities in vaccination distribution and vaccination strategy. And one of our other colleagues gave a talk on his experiences in Malawi, maybe known to you, where 80% of the population are what we would call tested positive.
Yes.
And what is the method there? Is vaccination important there? What is the method in those kinds of countries that can be used when you've got those with the associated poverty and the associated comorbidities and vulnerabilities? What do
It's
you?
super difficult, but the experience that we've had is that actually the vaccination in African nations, once it's properly organised, reduces severe illness and death. Remarkably effective, these vaccines, and where they're properly organised and made available, the impact is great. It's just that the supply has been very bumpy. Quite often, the donations that are offered to poorer countries have very short time shelf life and then expire quickly. And we haven't been able to get a proper global vaccination program organised. It's because wealthier nations wanted to make sure they could get as many vaccines as quickly as possible. And the global system hasn't worked. I would agree that if we were saying one thing needs to be given a priority right now, it is to enable more vaccines to be properly supplied with a supportive program that's adequately funded so that vaccination can be made more widely available, just for the sake of trying to reduce the overall amount of virus that's in the world and trying to reduce the opportunities for new variants to emerge. There's just too much virus around at the moment, too many opportunities for mutations leading to variants that will cause trouble and will go on appearing in the coming months and years. So that's why I agree with everybody who's saying let us focus on vaccine equity and getting fair shares of vaccine across the world rather than having it just concentrated in a few countries.
They're right. I mean, they related to that. There's the question about compulsory vaccination.
Yes.
Medical and healthcare workers.
Yeah.
Do you think that from your the way you worded it, I would assume that you would not favour mandatory vaccination for certain professions or certain parts of the population. What are your views on that?
If it is possible through dialogue to reach a point where it is agreed among the majority of people in society that there should be some form of not so much compulsion, but really strong incentive for people to be vaccinated, and the justification is extremely clearly laid out, then I think there's a case for societies to conclude that some sort of legal measure could be applied. But in general, I would say please avoid it, because all our experience is that as soon as you compel people to do things, there will be resistance. And as soon as you've got any kind of tension like that, it will become politicized and it will make the application of public health measures very, very difficult. And as I said when I was giving my earlier remarks, it very quickly spreads beyond the pandemic. So it becomes a much bigger issue. It reveals schisms in societies. We say all the time that COVID is the great revealer. It's showing some of the tensions and vulnerabilities in our society. So as soon as you start to introduce a compulsion, you make those schisms much more visible and it becomes much more dangerous. And our sense is that the use of compulsion is just a really unwise thing to do in today's world. Unwise because we don't know what the ramifications are going to be, and we are sensing more and more that it's leading to a real polarization of opinions in society. So where possible, we're pleading with governments. It's not in a sort of a weak way, but pleading with governments with strength, with evidence, and with concern as well, that compulsion should be absolutely a last resort.
Then, in addition to that, we've had a question in relation to the so-called long COVID.
Yes.
This is a phenomenon. Is this a phenomenon that's being discussed only in the wealthy Western world, or is this international? And what are your thoughts about how that needs to be regulated?
Well, for a start, there is no doubt that this virus has long-term impacts on a proportion of the people it infects. And it doesn't seem that the nature of the long-term impact is directly related to the original infection. So there's a lot still to be understood. Whether this is a global phenomenon is not clear, because there hasn't been the research in many places. It's just starting, and the World Health Organization is actually pulling together, convening a multi-center investigation of this. And I suppose what I'm trying to say to people is that we don't know what the long-term sequelae of the different variants are going to be, and we have some understanding that they're likely to involve problems with the cardiovascular system, and they're also likely to be involving the central nervous system. And I suppose that's why I do say that it's not wise to just avoid controlling the transmission of this virus, because the more people are getting infected, the more long COVID they are going to experience. And because we cannot be clear to people what the likely implications of this long COVID are going to be for them intellectually or for them physically in terms of exercise and the like, we're just saying, be careful. Just don't let all the kind of personal protections go. Keep up wearing the masks, keep up maintaining physical distance, and try to treat this virus with respect. You don't want to be infected with it if you can avoid it, is our view.
One of the issues is spoken about the vaccine distribution.
Yes.
Vaccination is not the answer completely. What about the question of antivirals? And in light of what you said, what about the question of equity of distribution of antivirals?
Yes.
Should they work?
Well, I would want to see much greater investment in exploration of options for treatment. Now, there are various directions that could be looked at. A lot of the people who become severely ill with this virus are ill because of their immune responses to it. And that's why one of the early discoveries was that dexamethasone is a lifesaver, because it does, as we all know, it reduces the immune response. And now there's other ideas that perhaps adding in additional quite low cost treatments like spironolactone could get better results with an even lower dose of dexamethasone. So what I think I would like to see is a much greater proper investigation of a variety of different treatments, including checking to see some of those that are widely discussed, like ivermectin, just showing clearly the disadvantages of trying to treat people with that kind of treatment, but then looking at the ones that have promise. And then at the same time, investing in the development of new generation of antivirals. And we've had several that are now coming on stream and have got a lot of promise. And I would put much more money into trying to get more of these preparations properly trialed, and then I would also invest in making them available globally. Because the one thing that is really worrying me is that there are people who are getting COVID and for whom treatment is really difficult. I mean, in many countries at the moment, you go over in the East in Asia, you've got reports of grossly overloaded hospitals and facilities just not able to cope. And so, yes, I would like to see treatment much more widely available, particularly for people in poor countries, both the repurposing of existing medications and also the development of new medications. If I had the resources, that's where I'd be putting them. If you look at the amount that's been invested in vaccine development, it's much, much greater than the amount invested in the development of new therapies or repurposing the existing ones.
Daniel Morgenstein is talking about the younger children.
Yes.
And the patients he looked after with COVID, even the younger inpatients were overweight, and they had features of metabolic syndrome. And since the vaccination program started, we've lost focus on looking at questions like health, fitness, diet, etc.
Yeah.
To reduce the risks of severe disease. I mean, is this a lost opportunity? Should the COVID lobby, if you like, as represented by yourself, be also saying those are important issues?
Totally. I mean, I think people like me should be faulted for sometimes spending far too much time talking about sort of issues that perhaps are not really relevant to everybody. I'm just trying to be careful not to put my foot in it. But I think that just echoing what you've just said, it's quite clear that an awful lot depends on a well-functioning immune system, and a well-functioning immune system depends on keeping oneself in good health, good nutrition, plenty of exercise and sleep and all the rest. And I think that's incredibly important.
Daniel Morgenstein needs to take that up with the British government. I hope that I hope he's successful. I mean, it's a very difficult task, as you no doubt know only too well. I mean, one of the questions that has arisen in that context. If you mentioned that the severe lung disease and the possibility of neurological disease.
Yeah.
I mean, neurological disease, there's a history of neurological disease being an outcome of pandemics in the past.
Yes.
What are we doing about checking on neurological disease prospectively not in Britain, but in Asia, for example? Are they looking for neurological disease there, or is it just by chance that the patient comes along and presents with long COVID and has neurological findings?
So, I mean, there's some really important studies underway, particularly in India. I don't know the full details, and it's something almost I'd like to say I'll follow it up and get back to you, because the team in WHO who are working on long COVID actually interacted with myself and the other envoys quite recently. And what's clear is that this has suddenly become an absolutely massive issue because of the recognition that the potential for longer term pathology is there, and we just don't understand which people are going to experience it, nor is there clarity on the full spectrum of different sequelae that exist. So it's just an area that will unfold, and yes, people can, I think, contribute. There's all sorts of ways in which one can contribute through observational studies and other such things, through various trial registers. So yes, I think anybody who is in a position to look at such things should be, well, certainly contacting the World Health Organization, who are creating the necessary platforms for collecting together lots of observational studies, because that's how long COVID will get fully understood, is through observational studies first, and then the more careful cohort longitudinal studies will come.
You referred to the new mutation.
Yes.
Potential.
Yes.
One of the questions that, from my laboratory medicine vantage point, one is asking is that it's all very well, but if you're relying on lateral flow tests rather than PCR, the number of samples that are going through the PCR process, which is the way that the mutation is detected, is going to be decreased in the UK. And presumably the same thing's happening in other countries. I mean, is the search for mutations going to be maintained? And is the WHO somehow pressing for that?
WHO's put an enormous effort into making sure that there is a network of laboratories that are capable of doing sequencing in order to pick up the variants. They don't reliably get picked up through PCR. There's something rather unusual about Omicron that meant that you could pick it up on the PCR, but that was not what we will use as the basis for the effort to find potential variants. That's done, as I say, through a well-developed network of laboratories and extremely clear protocols for picking up variants. I actually think that the capacity to detect variants globally is quite good, and Britain's had quite an involvement in helping to set that up.
Yeah,
so that's okay. What will not be consistent, I think, is the records of numbers of cases around the world. At the moment, we have an extraordinary system where through regular reporting we get numbers of cases, and recently they've been up in the millions every day. So that will start to be even less reliable than it has been up to now, because quite simply the testing will not be able to keep pace and is not able to keep pace with the numbers of cases. Yeah, so that's the difficult part, and we will not be as reliably informed of the epidemiology because testing schemes are going to be shifting quite markedly, and that means that knowing what's happening with the pandemic will get a little bit more difficult, actually.
Will be more difficult. I mean, was the samples taken? The samples for lateral flow tests that we've been advised to do in Britain are not, the samples are not going to a central laboratory
No,
in the way
everything.
the PCRs are.
No, and so the numbers for, well, I'm trying again. I am not going to put my foot in it. So numbers will not necessarily tell the full story for all sorts of reasons. How about that?
Right, right. I leave that. Marcia Schofield's come back with the question. Somebody has to use the words anti-vax,
Yes.
and she's perfectly correct that the anti-vax community uses pseudoscience and social media. So how can you use citizen science to ensure that reliable information gets out?
Oh, I think that.
Evidence.
I mean, there's a load of groups trying really hard to address the capacity of conspiracy theorists to dominate the airwaves and social media and so on. But the reality is that it is quite attractive to think in terms of some kind of manipulative process in which we're all trapped. And then one of the reasons why it's attractive to get there is that we actually don't know enough about the virus to be able to explain to people what we can reliably say is going to happen. So there's, for many of us, this rather frustrating way of speaking where I have to say to people, sorry, I don't know. I don't know when the next variant is going to come. I don't know what this is going to mean for how we're going to be living in the next year or two. And I think it is that the fact that we don't know, and perhaps also that then leads to the quite substantial amount of argument between different protagonists of different ideas. And then that creates such an opportunity for people who want to encourage unusual beliefs to emerge to perhaps gain adherence. But I'm not surprised that it's happening. I mean, why should people believe me with my uncertainties any more than anybody else? And I keep thinking that this is part of what we are going to have to live with for the foreseeable future. And the only way to counter it is through people being as authentic as possible when they talk about what's happening, and actually not to exaggerate at the same time and not to make unreal promises. So that's my direction, is that anti-vax is powered by mistrust and by frustration, and that mistrust and frustration is in turn possibly contributed to by people who don't always speak with authenticity. So let's at least try to get as much honesty and I suppose humility into communications about this, with hope where it's justified, but at the same time just avoiding exaggeration and so on, because this is going to be with us for the foreseeable future. We may be lucky and that there may be no more nasty variants, and then people like me will be eating humble pie a bit. But at the same time, I think at least I'm encouraging everybody to be as prudent as they can.
And I mean, one question that's not been asked on the chat, but is the one question is the title. Most of us have never heard of a special agent. This is a new phenomenon. Does the UK, were you the special agent on Ebola virus, for example?
No, it was.
And how did this arise, and what?
No, it's envoy. It's envoy. Envoy. I must tell you that the actual word is envoy, special envoy, right. And what it means is that you're there to work on behalf of the head of the WHO. So I'm special envoy of the Director General. And I have 4 things that I'm asked to do. The first is to amplify what he's saying. And if I get the chance, for example, to go on the radio or something to explain what it is that the WHO stands for and what it's trying to achieve with this pandemic. Second thing I'm asked to do is to interpret what that WHO guidance is in different settings for businesses or for governments or for cities, and to help it sort of work out what that means for schools or what it means for factories and the like. The third thing is that some leaders ask me to actually be alongside them and to meet up with them, and sometimes or to have conversations with them, to go through options, accompanying them while they make really quite tricky decisions, because many are. And then the fourth thing I do is to feed back to the WHO saying, well, I picked up this or I heard that. It's an unpaid role, but it's like a kind of ambassador, and that's what I do. I've been doing it really since January in 2020 for the Director General, and we connect every week and all that sort of stuff, and that's how I keep being, I suppose, up to date with what it is that's going on around the world.
Right. So you are part of the WHO and not answerable in any way to the British government, even though you were originally linked to the British government when you went.
I was with the British government until 1999, and then I went and worked for the World Health Organization. And then I worked for the United Nations on lots of different things, on food, on pandemics and different other nutrition, climate. And then I left the United Nations and everything after I'd done these various different roles in the middle of 2017. And I've been working independently. I teach leadership and so on. Been working on food and I'm working on COVID, and my most recent work on COVID is for the World Health Organization as an independent person, because I'm also a teacher at Imperial College in London, and I am, as I say, working on their behalf. So I'm their special envoy.
Right. Because one of the features, of course, is that many of the other famous viruses have all had very articulate envoys to discuss them.
Yes.
Maybe one of Britain's oldest and most eminent virologists is Tony Epstein, of course.
Yes.
Speaks very eloquently always about Epstein-Barr virus.
Yes.
And I think we end on that note to say thank you very much.
Thank you.
And you've certainly acted as an envoy for sensible thinking about the coronavirus, as well as for explaining a lot about the virus itself, which is what Tony does. And if you want to have a kind of Jewish Medical Association wish at the end, Tony is well over 100 already, so may you continue to be working hard and being effective as long as that.
Oh, thank you. That is the kindest thing to say. And David, I've enjoyed tonight very much, and I hope that if it's possible, we can reconnect and follow up. I'd enjoy picking up on any reactions you get. And thank you again.
Thank you.
Bye-bye.